iBleep is a task management system and a clinical communication tool that has significant benefits over a traditional pager. First of all, let's examine the traditional pager. A doctor receives many page calls and has no idea of why they're being called. The doctor needs to find a telephone, call the ward, speak to the correct nurse, and determine why they're being called. And page calls are often repetitive, it can be invasive, and offer no audit in the event of a clinical incident. The technology is a legacy of the 80s and is a very inefficient method of alerting a doctor, particularly to a potentially deteriorating patient. iBleep calls are not raised through a paging system. They are raised by the ward nurse entering some basic information about the patient into a ward computer. That computer is connected to our servers in the UK. Doctors carry a smartphone or a wireless PDA, and these are connected to the same network as the ward computer. The device plays an audible alert when the call arrives, and these alerts change in frequency according to the type of call. So from a doctor's perspective, how is iBleep so different? It provides concise information about my patient. It gives a clear indication of the problem, and that's without having to find a telephone. It shows me where I'm needed, even which bed to go to. But is this call urgent? Calls are ranked red, amber and green, with red calls being the highest priority. They're set by the organisation and help to describe the call. Observation detail is added, and this is converted into an early warning score that helps to prioritise the call. The most important call is always at the top of the screen. Even if I have 10 or more outstanding jobs, I get to see that observation detail too. That helps me to make an assessment of the patient before I actually get bedside. The moment that the call is read by the doctor, a message goes back to the ward to inform the nurse that the doctor is aware of the call. There is no need for the nurse to be waiting by the telephone for the doctor to call back. So why not just give a doctor a mobile phone and call him? Because it would be disruptive, even more disruptive than a pager. Let's look at a fairly typical scenario with a doctor involved with a discussion with relatives, for example. A paged alert for a low priority job arrives after a few minutes. That's the one marked L in the top left corner. A second alert requiring urgent assessment arrives after 20 minutes. That's the one marked H next to it. The discussion ends and the doctor calls the ward that raised the first call. It's not urgent. He then calls the second ward. The nurse is waiting by the phone and describes the call, and an urgent action takes place as a result. But look what happened. 10 minutes were wasted by the doctor, having to call the wards. 15 minutes were wasted by the nurse, having to wait by the phone. She may have already started to page the doctor again. The response to the action was delayed by 20 minutes. It failed the doctor, it failed the nurse, and it failed the patient. Examine the same scenario now with intelligent bleeping. The first call arrives and the doctor can see that no action is required. The second call arrives and the doctor is immediately informed that urgent intervention is needed. The discussion ends at this point and the doctor attends the call. That's immediate assessment, no time wasted. And this is why intelligent bleeping is so important. By tapping on selected icons on the screen, a doctor can interact with the call and can advise whether on the way, bedside, etc. And this information is immediately shared with other wards and members of the team, and it's also stored inside iBleep. The doctor advises that they've arrived bedside, and this information is shared with the team. The doctor makes a decision to stay with the patient, and he locks into the call. This information is shared with the team and other wards, and will protect the doctor from similar high-priority work that he has no possibility to attend. I mentioned earlier that one of the failings of the traditional pager is that there is no audit, and that in itself can obscure responsibility and accountability. Where iBleep also succeeds is its role in allowing calls to be filtered directly from a ward to a clinical coordinator or a nurse practitioner. This is particularly effective in an out-of-hours scenario and fits in very well with the Hospital at Night initiative. iBleep allows calls to be filtered to a night practitioner and then reassigned to a junior doctor according to experience, availability and location, etc. And of course, all of this is in iBleep's data trail. iBleep creates a lot of audit data, and it provides a suite of reporting tools to access it. Whether you need to isolate one particular call, or maybe analyze call activity by ward or by specialty, etc. And understanding how, where, and when the workforce is deployed will give an organization the confidence to make changes to working practice and to streamline the workforce. For example, a doctor can spend a lot of time on routine work such as blood and fluid-related calls. And by adding specialist nurses to the team will improve efficiency and allow doctors to concentrate on the patients that need them the most. Inappropriate calls can be returned to the wards, especially if it's known that wards have the skills to deal with these calls themselves. Intelligent bleeping gives significant benefits to an organisation. We've seen how the delivery of relevant call data can impact and improve patient care. We've also seen how strong audit data provides the evidence to redefine and streamline the workforce. An organisation could begin to reduce the number of actual doctors employed at night. And those benefits will extend to the doctors too, with better daytime training, theatre, ward-round experience, and of course better sleep. But perhaps one of the most fundamental and transparent benefits is that it enforces accountability, that key factor in effective clinical governance. I'd like to introduce you to what we call the Auckland model. Auckland District Health Board in New Zealand had the vision to make iBleep work despite the distance between ourselves. There was no European Working Time Directive, no Hospital Night initiative. They recognised that by creating good communication they could improve working, replace old working practices and bring a little accountability into the workplace. In early 2008 they made that first investment in us and launched a 6-month pilot to be run over 6 wards. In just 2 months they asked to extend that trial to 25 wards as a result of requests from doctors and nursing staff. They now operate iBleep across all specialties, a total of 55 wards, and we achieved that without actually travelling to New Zealand. This is their quote. Auckland dealt with inappropriate calls and restructured their workforce. They added roles of clinical nurse advisor, and senior nurses were retrained to fill these roles. They completed an advanced acute care program at the University of Auckland, which comprised 50% theory, 50% practical, and this was signed off by senior medical officers. They added full-time cannulators and microcollects. They even added midwifery advisors. Across these roles, they currently undertake more than 25% of work historically done by junior doctors, thus freeing up doctors to look after the patients that need them the most. The relationship between nurses and doctors has strengthened as a result, and the sicker patients benefit from a quicker and more holistic assessment. The CNA workforce includes multiple CNAs by specialty during the day and single CNA at night. More than 99% of iBleep calls are filtered or are sent directly to the support team. Most of all, iBleep has become a 24/7 tool and is adopted across all specialties. I'm not giving all the credit to Auckland. We created a new architecture that allows for multiple coordinating roles and 24/7 working. We added a core handover process that mimics physical handover so that 24/7 working is seamless. We've created alerts that change according to the urgency of the call, and these alerts will repeat until the call is read. By adding the ability to lock into a call, a doctor is protected from other high priority work that the doctor has no possibility to attend. And by creating lock alerts, we automatically alert the rest of the team, and this adds awareness. We added shadow assigning, giving more than one individual responsibility for a call. We provide access to search the BNF and still stay in contact with incoming iBleep calls. A doctor can see call history, their own 24-hour history or full call history per patient. The call raising process now identifies the nurse so the doctor knows who to speak with if they need to phone the ward. Auto call escalation gives a junior doctor specialty-based support. The whole team is now supported by unread call alerts because unread calls are a risk to patient safety. We've created a solution that is secure, stable and future-proof, and if it works 13,000 miles away every day and without interruption, then it will work anywhere. iBleep improves the service quite simply by providing effective clinical governance, and clinical governance embodies 3 key attributes: recognisable high standards of care, transparent responsibility and accountability for those standards, and a constant dynamic of improvement. This definition could never be applied to a pager.